Good morning, all, and welcome to our first DEI Symposium. We are so very happy to have you here with us and very excited to have such an amazing, wonderful, dynamic group of speakers on the important topic of diversity, equity, and inclusion. You know, the area of DEI is, of course, a very large one and one that has been evolving over many years as we strive to create an environment where all can thrive regardless of race, ethnicity, sexual identity, physical or mental health challenges. You know, what we know is that change tends to be a slow, ongoing process, but it is often punctuated by bursts of intense focus. With the murder of Mr. George Floyd, we have had intensified focus on race and ethnicity and the disparities that exist. What we also know is that change, whether it be slow or intense, can only be sustained when we all lean in. And that's what you're all doing by being here today. The hope is that you will go home and with some new knowledge and action points for you personally, as well as some thoughts about change on the systems level, which is, of course, critically important. We will first hear today from Dr. Elena James on perspectives, broadening our view of healthcare beyond the healthcare complex. Please join us for the post-grand rounds meet and greet. This will be followed by 2 workshops highlighting recent work in changing the system or going beyond the system in some cases. At 9:30, we will be discussing creating and disseminating an anti-racism curriculum. At 10:45 will be discussion on working with community partners to reach out to marginalized communities to share vaccine knowledge and shots in arms. The noon hour topic will be the critically important area of stereotype threat. And now, it is my distinct pleasure and honor to introduce our grand round speaker, Dr. Elena James. Dr. James began her career as an undergrad at Yale University and then went on to Baylor University for both her medical degree as well as her PhD in biology. After interning in New Jersey, she did her residency in dermatology at the University of Pennsylvania, where she remained as faculty until 2012, when we were so very fortunate to woo her here to Pittsburgh as faculty. She is an assistant professor at the University of Pittsburgh School of Medicine in the Department of Dermatology, where she has excelled as a clinician, educator, mentor, and researcher. Her clinical focus is to ensure access to dermatology services in underserved local, rural, and global communities through outreach service learning programs. Her research has demonstrated the paucity of skin images with brown and black skin in dermatology textbooks and internet searches, leading her to develop a visual learning program to audit and improve diversity in visual learning images. She has also published a critically important article, An Anti-Racism Plan in Dermatology and the Role of Community Service in Dermatology Resident Training Programs. It is therefore not surprising then that in 2018, Dr. James became the founding director of SHE, the Skin Health Equity Program, which addresses access to education, workforce, and inequities in dermatology. And this past year, she became affiliate faculty in both the Center for Health Equity as well as the Clinical and Translation Service Institute. Dr. James is dedicated in her role as an educator, mentoring Pitt undergrads in the continuing research experience. She facilitates medical student small group learning and is a mentor for the Dermatology Interest Group Community Clinic. In 2020, she created a new anti-racism curriculum, Racism in Medicine, bringing in multidisciplinary contact experts to help students understand individual, institutional, and structural racism and its impact on healthcare with the goal of developing equitable approaches to healthcare. Again, not surprisingly, her awards are numerous, including the Dermatology Teaching Award and the CTSI Innovation Award, both in 2019, as well as the Medical Student Research Mentoring Merit Award this past year. She has already mentored numerous students and trainees from the undergraduate level all the way to folks who are already physicians seeking to learn about equitable care, not just in dermatology, but also very importantly, equitable care in all facets of the medical arena, including community-based care. So this is why it is truly my pleasure and honor to introduce Dr. Elena James, a dedicated researcher, educator, mentor, and tireless champion for access to equitable care. Dr. James.
Thank you so much for that kind introduction. I really appreciate it. I'm very honored and blessed to be with you in this space to talk about such critical issues that we are dealing with. And so with that introduction, I'm going to highlight sort of how I have evolved over time, the ups and downs on my journey towards making and creating a skin health equity program, and the ins and outs of it. So that introduction was so beautiful and sounds so great, but I want to uncover some of the issues and challenges that I've experienced along the way. And as a dermatologist, the focus of this talk is really on view and vision and perspective. And that's really important to me as a dermatologist because I am trained to use my eye to observe, to diagnose, to treat things. And so what we're seeing and what we understand in DEI is very, very important. And so there's a portion of this talk that is learning objective focused, and we really want to hit home some crucial topics and definitions to make sure that we're all on the same page. But there are also a different layer of understanding and thinking that I want to emphasize that we need to deal with, and that's our feelings, our mindset, our emotions, and personally what we are dealing with when we talk about DEI. And so starting off, we're going to talk about health and health equity. We're going to examine our perspectives on healthcare, describe societal factors and powers which impact health, and then we're going to close and wrap up with strategies and plans and looking towards the future and maybe switching or shifting our perspective. I have no financial disclosures to share. I do have a lot of personal disclosures that I'm hoping you'll be patient with me as I talk about them and just give you a view of my journey over time on this pathway. Starting with perspective, I always really liked root words and meanings. It helped me a lot in medical school to understand the Latin root words and what the prefix or suffix meant so that you could look at a word and kind of understand it. And so perspective is very interesting to me because per meaning through and spective meaning looking. So how we look at something or the direction at which someone's looking at an object or an issue or a problem really, really impacts how they understand it. And so this ability to understand or see what is important really depends on where we stand, where we go, where we travel, the people we engage with. And based on that perspective, that observation, that impacts, what we believe, what actions or goals or aims that we have. And I'm hoping to show and explore how if we find ourselves in different environments and different places that maybe our perspective will shift. Maybe we will see what other people are seeing. And that's an important topic because we know that there's a lot of issues where people are at polar opposite ends of the spectrum. I believe this, I'm against this, I'm against this. But maybe if we shift and rotate closer to those people or thoughts that are opposite of us, that maybe we would have a little bit of a better understanding and then would have more room to discuss and explore these issues. And I do want to take a moment just to pause and ask you to reflect about your journey, because I'm going to share my journey with you, but I want you to pause and reflect about your journey in your career, in the health professions, and where you have come from, where you are, and where you are going. Because in this DEI work, oftentimes we're putting our energy into solving issue after problem after problem. And if sometimes we don't just sit quietly and think about our journey and where we've come from, where we are and where we want to be, then sometimes it can just be too heavy. The vision can be very narrow and the work can be very hard. So I want to take you on a journey that the introduction kind of highlighted as to how I got to where I am and how my perspective helped shape a lot of the work that I've done and the influence of others on my journey. So in 2008, I was wrapping up my dermatology residency. It was a bit of a challenge. I had 2 children. I experienced a miscarriage during residency. And at the end of my residency, I was pregnant with twins, had to go on bed rest. And so that extended my term as my residency. So I finished off cycle, challenges with taking the boards because of multiple issues. And so it was a race and it was a challenge. And I was dealing with, my family and trying to focus on my family and the family that I was building. And parents were getting older and a lot was happening at the University of Pennsylvania. I was fortunate and blessed enough to accept a position as assistant professor at the University of Pennsylvania. And at that time, my vision was very clear. I wanted to be a practicing dermatologist in West Philadelphia. I really wanted to be in the heart of that neighborhood and community and serve the people there, which is a predominantly underserved, medically marginalized community of mostly Black and brown people. And so I was doing this work, developing this practice, had the full support of the University of Pennsylvania. And then about 2011 and 2012, I could hear the call to come back home to Western Pennsylvania. I'm originally from Beaver Falls, and that is the place that I eagerly left and never wanted to come back because just being a Black woman in Western Pennsylvania was very challenging. Just my sheer existence was a challenge. And so I fled from this area in search of other communities that had more strength, that had more diversity, that had more support systems. And I found that in Houston. I found that in Philadelphia, but I knew I had to come home to help with the care of my parents as they were aging. My mother was diagnosed with onset of Alzheimer's and it was time to come home, but I really wasn't prepared mentally, emotionally to come back to this place. I was happy and fortunate to accept a position at the University of Pittsburgh and to start my career. But when I came, I had to settle in very quickly with 4 children, a husband with a great career who was traveling and figuring out the landscape here. And so I kind of put my head down and just got to work and started to take care of patients. It was patient care, doing the best I could as a dermatologist in my setting to deliver care, and nothing more than that. And so I was working hard, family was adjusting, getting acclimated to this new setting, this new way of living and relating to people. And then in 2017, a couple of things happened. I received an email from a medical student, and I really was not engaged with the medical school at all. I was doing my UPMC focus work, even though I was dually employed, and really was not engaged with what was happening at the School of Medicine. So I was actually surprised, and this email came, and it was explaining what her experience was in medical school, and I was shocked and amazed for multiple reasons. One, because her experience in 2017 was my experience when I was in medical school, close to 2 decades ago. I just could not believe that she was experiencing the same thing that I experienced. My assumption, ignorantly, was that we had progressed, that things had gotten better simply on their own, but she had noticed that there was the lack of representation of diverse patient images in her learning. And she noticed this across the board and wanted to do something about it and was asking for my help. And this hit me very hard because I was not in a position to help in any way. In my work and what I was doing, I had basically isolated myself in a mode of survival to help balance work and home and everything else, that I was just focusing in on patient care and not exploring and connecting and networking with folks around me. And so I was disappointed in myself. I was disappointed in what was happening. And so based on this, this was an awakening for me. It was an awakening of my awareness that I had sort of put aside. I had always been passionate and a champion of the underserved and people who were being oppressed. That was in me, but I had to quiet that for a while in order to right my life, to get things in order. But this email really triggered me, and it helped to open up my awareness, look at my surroundings, and change my perspective. And it also did uncover underlying anger that resided in me very deeply about the way we care for and value people, the way we treat people, what is important to us and what is our focus to us. And so I was at this place of comfort. I had a good job, good hours, good flow, good support staff, but I was tired. I was a little bit weary, and I was working in isolation at a huge university, a huge healthcare complex. I had found myself working very independently, but in isolation. And that is a very dangerous place to be because there aren't folks to help you, to motivate you, to support you, to guide you. And so I knew things had to change. And oftentimes people would ask me, how's work? How are things? And I didn't have really huge complaints, but I knew in my heart that where I was in the wrong place. Things weren't the way they should be. And it was almost an uncomfortable comfort. I was too comfortable for what was happening around me. And so I knew that I had to change my perspective. And I started to think about how I was viewing things over time. And really early in my childhood, I knew that I wanted to be a doctor. I think it was third or fourth grade, we did a scientific experiment on dissection, and we were dissecting a frog. And for some reason in my mind, I thought that when we opened up the frog that it was just going to be mushy and just stuff inside there. But I was amazed that everything was so neatly packed and organized and connected. It was a machine, and it had a purpose and a reason for why it was situated this way and connected this way. And each individual part was doing its own function, but working in concert to help the body to do its activities. And so I was like, wow, if people understood how the body works, then they would be able to take care of themselves. And it was really my goal to help people understand, first me understand about the body, and I was very curious about it, but wanting to share this knowledge and say, look, this is how your body works, and if you understand that, then you'll be able to take care of it. And so I always saw it in a way to help people. But as I went along this journey, this perspective really became focused on me, my success as a student, my hard work, my drive. And I was praised and progressed based on this individual success. And sometimes it may have been about patients, but it was really about what I was doing, what I was accomplishing as an individual, and in a hierarchical way. So the better you did in this evaluation of knowledge and care, the more praised and the more success you had as an individual. And that speaks to some of our frame of work of what we're looking at is me. What am I doing? How am I doing? How am I succeeding? And less on what my childhood desire was to take this information and share it wholly, to give it to people, to help them be well, to help them have good health. And so as faculty, I had arrived, and the focus became on patient care, productivity, how many patients, how well am I doing, press gaining, and less about those relationships. Is, patient X getting better? Have we given patient X all of the support that she or he needs to live a healthy life and to have, good mental health? And more about, I've given the diagnosis, I've given the treatment. And so with this, I sat down with my daughter, who was about 8 years old at the time, and she was really into doodling, and she would doodle stories. And so she would tell a story and she would doodle it out. And it was quite amazing to watch her do it. And I said, well, Zora, I want to tell you a story and I want you to doodle it and show me what you make. So I sat down across from her and I said, Zora, this is kind of what my day is like at work. And so she's doodling and she's like, well, what else? Tell me more details. And I was like, sometimes, people are catching 3 buses to get to me, or sometimes they arrive late, and because they're arriving late, it may mess up the schedule, and then I may be asked if I want to see the patient or tell the patient to come another day. And I was like, and sometimes it's very confusing and it's very busy and hectic, almost chaotic. And so she's drawing and she's drawing. And I said, but really my heart's desire is to just help people and to talk with people and to understand what they need and to help them along their journey to be healthy and well through the treatment of their skin. And so when she was finished, she showed me this picture. And I was like in awe. I was like, wow, this is me. And she has me looking a little bit crazy. And I want to help people, but there's all of this chaos and confusion and people trying to get to me and the traffic in Oakland and all of these things and people running late and worried about childcare. And do I have the right directions? I'm at the wrong office. Did you change offices? And so I had to look at this and see this and understand this and change my perspective. And so this was really important when she showed me her vision of what I was doing. And so the change of my perspective, I had to have an action plan. I'm an action-oriented person. I'm like, what are we doing? What is our plan to figure out how we can fix this? And so I had to change my perspective. And I had to pay less attention to myself and focus more on, what was happening in society, what was happening at the School of Medicine, the experience of that medical student, and what was happening less about me and my productivity and my success, and going along on this journey of what is considered success in the healthcare arena. I did have to sit and think about my anger. And that was a really, really big thing for me, is uncovering and thinking about why I am so angry about the way things are. And, my daughter uses the terms, and what about it? Like, yes, I am angry. And there's a stereotypical angry Black woman that you hear about. And my response initially is, and what about it? Like, rightly so. I think that I have a right to be angry about what is happening. But that anger, I know, can eat away at me. And if I'm leading my efforts with anger and not love and not support, then that can affect my effectiveness personally. It can affect sort of how I'm stressed out and dealing with everything. And so I had to think about my anger. And when I really thought about it, for me, it was truly a sadness, a really just hurt that people, myself included, were not looking at what was happening outside of the healthcare complex, that we were so focused on doing our best, and a lot of us are doing our best in this arena. But go back to that image that my daughter produced, it's chaotic. It's very challenging for all patients to be able to see me, there, to be able to travel from Erie for a 10-minute dermatology appointment. And so I had to understand that I was really sad and hurt, and lead from that and not from so much the anger. I also had to get myself out of isolation. I had to figure out a way to network. And when I came here, I was told that the environment that you're entering is a sink or swim. Like, if you can do it, if you can swim, you'll be fine. You will be great. But if you need a lot of support or hand holding, you may sink. So you need to come out ready to swim. And I found myself not swimming, not sinking, but treading, just staying in one place and treading water. And you know how exhausting treading water can be after a period of time. And so I knew that I needed a team, folks to help me and guide me. And so I literally started knocking on doors, started just showing up in meetings, finding out where they were talking about the curriculum, showing up and figuring out how this worked in order to address the question that the student came to me with. I wasn't able to help her at the time, but I was darn sure going to figure out a way to make a change. And so I started asking for help. And when I stopped, vigorously treading water and looked up, I saw that there were a lot of people around me, and I just had to reach out and say, will you help me? Will you show me the way? Will you tell me where I need to go or what I need to do? And those people were definitely there, and I'm very grateful for those people. I had to research the problems. I had to understand what I was talking about and what I was really trying to do. I wanted to just jump in and show up at places and say, I'm here to help. I wanted to be in the community and working with the community, but I had to figure out how to do that. And so I started to look at people who were doing this work and what were they doing, and basically stalking them. Poor Dr. Bowie, I was following her everywhere to figure out what she was doing, who she was connected with, so that I could do it in the world of dermatology. Dr. Pettigrew, I was asking him, what do I need to do to be connected to the students? And so these folks were helping me and guiding me along the way. And then I needed to make a strategic plan. What are we going to do? How are we going to do it? And always leading with the fact of why we are doing it, because people have value. And it's very important that we invest in our people and we help our people, whatever their needs are and whatever they're saying they need. And again, take the focus off of myself and looking more at others, what's happening around me. And so with basic sort of definitions, I wanted to look at health and what health is and what health means. And health is just more of just feeling well. It has to do with our physical being, our social well-being, and our mental. And it's not just the absence of not having a sickness or illness or a skin disease. And then I wanted to look at health equity and what that means in building this skin health equity program, and understanding that everyone, equity has value, right? And even to the point that that value is really equal. And I think that that may be difficult for everyone to understand, is that my value in this hierarchical system, truly, when we think about it, we are equal in being human and being people, and who we bring to, whatever situation it is. Just at baseline, my existence is of value. Who I am, however you identify me, with the intersection of my womanhood, with my Blackness, my Christianity, my cisness, all of those things, as you identify, regardless of those, I myself have value. And the person next to me has that same value, simply as being a human being. And when we look at this equity, understanding that to achieve it, we have to get around, over, through the discrimination that exists based in our society of these identifiers. And we have to help folks have power, have agency on who they are and what they do. And this involves jobs, education, housing, environments, and healthcare. And then looking at the inequities is when there's a difference based on unjust and unfair socially determined circumstances. And so our society, the lens of our society and everything that's happening is really important as to how we are able to deliver health care. And that leads us to think about the social determinants of health and how all of these factors, our economics, our neighborhoods, education, food, our communities come into play. And we can't just separate out healthcare without addressing these issues. I can't tell a patient to eat well when I'm talking about their hidradenitis, to eat healthy, to avoid sugar, if I haven't taken into consideration what they are available to have, their food insecurity. I have to take into consideration all of these things. I can't just be the 20% of the social determinants of health and stand there as healthcare and say, you take care of the rest. I'm here as a provider to deliver your care, and ignore the other social determinants of health. It's all integrated. And so when we look at Pittsburgh and we look at Allegheny County Health and the social determinants that impact us, there's a lot of information that shows where we have this huge healthcare complex in the center of Allegheny County. What's happening around us? What's happening in our communities? And really looking closely at this data: infant mortality, Black women's health, Black children, what they're experiencing. And we have it to a layer where we can look at zip codes. We can look at health census tracts and see environmentally what people are exposed to, and in turn, what environments are ending up with asthma flares in the emergency room. And we have that information, and this is information that we have to critically analyze and take into consideration when we're seeing patients come again and again to the emergency room for care of their asthma, and we're thinking, oh, the medications, they're not taking it properly. No, maybe at home, those are the triggers, those are the exposures that they have, which are driving sort of their health. And so we have to look very closely at that. And so when we think of health equity, there's a lot that goes into it, many layers. And those upstream factors are all of the intersections of who we are in this society and what discrimination, what oppression we experience, basically based on our personhood. Just who I am can affect my health. I'm not even talking about genetics, which are the downstream factors, more on the micro layer, but on the macro layer, looking at how these social factors are affecting our health, how institutional and structural laws and policies and governments and schools are affecting the health. And then the neighborhood, our workplace, our exposures in our communities. And that is the upstream, our society, how it is structured, which are truly governing the health of our people. And then we have, the decision making of risk factors, what people know about their health, healthcare access, and then the person and their genetics, which are more downstream, the micro things that are happening, that all come into play so importantly with health status, mortality, health, and well-being. And so we have to think of all of these things when we are addressing health equity. And this is layered upon how it impacts us as an individual, the individuals we interact with, our institutions, and structurally our society, and looking at this framework from all of these vantage points. Me as a person, what am I doing? How am I engaging? How is my institution engaging with health equity? And then structurally looking at our society. So looking at all of those lenses. Then the other thing I want to emphasize in the training modules that I've been doing in my reading is the importance of power and power in health, and the ability for people to act and have control over their health, their social factors. And that really has to be the focus on the global view, on the big view of health, is giving or sharing or helping people develop power. And so that they can care for themselves, that they can make decisions for themselves, that they have the ability to act on moving out of an environment or moving their children to a different school or having a better school. And so when we look at people who are experiencing these inequities, it's usually because folks don't have power. They don't have agency to act on their own well-being and their health. And so some of the ways that we can help in communities by listening to communities and engaging with communities is on a spectrum. And the spectrum can be a beginning point where we are, sharing knowledge and sharing information. We're working with, planning together, and then we're acting together, coming up with these solutions as a group. Resource allocation, taking time to go from the university setting to the community and sharing those resources and learning together. And then with empowering, the community is directing and saying, this is what our community needs. This is what our community needs. And being there simply as a support system to help those things happen. And I think that that's an important framework for me to think about how I can engage with the community. Is being there, arriving, listening, and then acting accordingly to what the community is driving or saying is important. And we have good examples. We are really making strides in this area within community engagement centers, and Pitt has committed, and we need that commitment. Not just to do a little volunteerism here or here, but a true commitment over time to work with communities, in communities, to support what the community is sitting down and saying and to do. And we are there to work with the community and listen and be directed as to ways that we can help. And we have a lot of great organizations that show their work in the communities, that are sustainable work that is happening. And I would love to see, as my vision shifts from now to the future, as us doing it as a collective, as a university working strategically in communities, communiversity working together. And so with this building of community and power in the community, we're really looking at community decision making. We're looking at establishing successful health strategies, programming that is sustainable, not one-offs. We're looking to measure data-driven, over time, tracking what is happening in these communities as a result of this work. Resource allocation, being a bridge from the university to the communities and moving back and forth between those environments and having that relationship. And then importantly, policies and laws and regulations and voting and understanding what are those governing forces that are impacting what is happening. And one important thing is that as we go from the healthcare complex, there needs to be a cultural shift in what we see as important and where we are putting our efforts as an institution for this to happen. The individuals can do the work, oftentimes very successfully, but the strength and the power and the successfulness happens when we do it in a unified fashion. So with skin health equity, I was trying to take in bits and pieces and come to a way, and it didn't happen very quickly. It happened slowly over time. It's basically taking that health equity framework and applying it specifically to skin and skin health through education, through access, and through career pathways and our workforce and developing programs. And so I never wanted to forget that email that it from the student that I wasn't able to directly address at that time, But as I started to get connected and started understanding, I went back to this theme, and we worked with 5 students, undergraduates and medical students, to really look closely and analyze what was happening as far as skin images, both in internet and dermatology textbooks. And we really wanted to look at the internet because so many people are using the internet to Google, to Bing, to look for information very quickly, both patients and health professions, just to get a sense, to get an idea, to get quick information. And so we wanted to analyze this and see what people were viewing, what was the understanding to answer the medical student's question. And a theme we call visual racism in dermatology, it's really important to understand that seeing skin color is really, really important. It really looks different based on the background skin type. So 2 people could have the same condition, like eczema, and it can look totally different. In darker skin, you don't see erythema, you don't see this pinkness, you don't see that sort of acuteness of it. You may, if you're not looking closely, only see dry skin, and it's thought to be ashiness, just moisturized. And the patient's very itchy and suffering, but this is eczema. And there may be a purple hue, and it may be subtle to the untrained eye, but there is inflammation present. And seeing those differences are so important. Otherwise, we are undertreating and not recognizing it. In the condition of pityriasis rosea, pinkness in a fairer skin, but a dark sort of color here and a grayscale. And then seeing conditions that look very dark and maybe not familiar with people, and the condition she had highlighted was the difference what happens when someone has lupus. And we know that there's great disparities in skin cancers and skin of color. It's often underdiagnosed and overlooked or not even assessed because it's not on the radar. And so these inequities are true and existing, but it's based on something. There's a root cause in why a lot of these things are overlooked. And so we wanted to strategically look at what is happening when people Google diagnoses and search for them, and what is happening in textbooks. And so if you put into the Google search and you put in warts, just warts, this is what will come up. And to me, this reminds me of grade school and going through history, or as a child going to the store and looking at baby dolls and seeing only white skin, and how that is hurtful, how that is traumatizing, and how that is saying that my skin color does not have value and is not in this discussion. And this is trauma to me. And so you search for another thing, acne, and it is very white-centered. And so in order for me to see something in brown skin, I have to put in a qualifier. I have to put acne, brown skin, or Asian skin in order to see, higher numbers. And this is a segregation of information. This is Jim Crow in a search, and it leads to bias. And people are learning that if I search, this is what I'm going to see, and this is what is of importance. And so when we looked, in a organized fashion and scored them across very common search terms, we saw that 80%, except for tinea, is where the majority of the color images. And this was true across all search engines, with very, very few in dark skin. And this shows the white centering of what we're seeing constantly through the day, and the messages that is being sent to us very subtly as to what is important, and it contributes to learned bias. And then we looked at major mainstream textbooks that are recommended and used in training, and we scored over 7,000 images and saw similar findings, that there was this white centering, and then medium skin was less, and then very dark skin was less. And there was a focus, and we looked at what were the most common diagnoses, where there was brown and black skin, was lichen planus, vitiligo, atopic dermatitis, and secondary syphilis. And this has been shown consistently throughout the literature, is that STIs are shown more in darker skin than in lighter skin. Again, these subtle messages that are being sent to us through our learning materials. And when we discussed this and we went through, submitting our manuscript, we went back and forth, and there were excuses and reasons that were given to us. And it was like the difficulty to photograph darker skin, which is really not true, because there are a lot of skin of color textbooks that do great jobs of showing it in darker skin. Limited space, well, with the space you have, it is very important for you to show these conditions in multiple skin types. And then there was this talk of the percent of the population, and that the percentage should represent the percentage of people in the population. And I failed to understand that, because as a dermatologist, I don't want to be able to diagnose only 10%. I want to be able to diagnose regardless of your skin type and understand it across the board, not based on the percentage of people of color that are in the community. And we know that is rapidly changing anyways. So we have proposed a way to, when we're talking about a condition in our conferences and when we're talking about it in education, to show it in a gradient, that any condition that is shown along a gradient. And that's important. So we see it in darker skin, we see it in medium skin, and we see it in white skin, so that we're understanding it in all cases. And so this has been one of our efforts in response to this question that I appreciate so greatly from this medical student, to bring this to the forefront of our discussions and our education. The other area that we're looking really closely at is dermatology deserts, both locally, rurally, and globally, and understanding that there are areas where in the white dermatologists are just not present, and it's mostly rural and minoritized communities, whereas dermatologists like to cluster in well-resourced, often white majority urban areas. And we know from studies that the distance from a dermatologist can really be impacted, the Breslow's death or the aggressiveness of a skin cancer. And poverty also can really impact it. And so we have been working towards breaking down these barriers, overcoming these barriers, and really figuring out ways to get to patients. And so we developed a program called MobileDerm, where we partner with communities and we go out to the communities and deliver the care according to what the community is requesting. And we're bridging this gap to access and cultivating relationships that are built on trust and respect for those communities. And this is really, really important, both locally and rurally, and taking our perspective away from the healthcare complex and really getting into the communities and understanding and delivering care there. And so a student has been looking at the Pittsburgh area and looking at different community practices and interviewing them, surveying them to understand what their skincare needs are for their population and whether we can partner with them. And so far we have partnerships with Birmingham. We have Northside that we're working with in Squirrel Hill Health Center. And this has been very impactful to understand what people need. And you can see my joy when we're at these clinics. And it's a different vibe, it's a different feel when everybody is really focused on holistically caring for patients. And we've worked with a student, Victoria, who's now going to dermatology at Harvard from Pitt Med School. And she devised a plan for residency programs to help them understand how they can partner with communities and how it can be a part of residency training to serve in these communities, and how that can help increase community mindedness. And these residents often are going off and figuring out a way individually to work with underserved areas. And so that is really important to us, to have that shared mutual benefit for health professionals as well as for the community practice. In our rural locations, we have 2 partners in Butler and Coalport, Pennsylvania, and we're really working on developing these relationships and working with the health professionals to share knowledge and increase their dermatology services that they offer to patients. We really want to do it in a way to better understand what patients' experiences are and preference for dermatologic care. And oftentimes we hear about telehealth, and we've offered these services, but from our survey studies, we're understanding that patients really don't have the technology to engage with teledermatology, and their preference is more towards a health professional who is coming to them and treating them, and not so much the teledermatology. When we go into communities, we often try to go as a team with residents, undergraduates, medical students, this vertical learning and working together. We like to engage with community health workers, the providers and professionals at the community, and we have the support of our dermatopathology team to offer these services to the community free. We've also gone abroad to Honduras as a service team. San Lorenzo, this country has one main dermatologist that we had the privilege to work with while we were there and engage with that dermatologist. During our week there, we saw over 500 patients and cared with them, and they did it in such a way that we really learned a lot about the way they organize their healthcare and the systems that we've used in our care when we go to community outreaches, and how they're doing pop-up clinics there in Honduras. So we've learned a lot in that partnership. And we also work with the Internal Medicine Global Health Program and have worked to go to Malawi, Africa, and bring our residents to there to work with the providers that are there and work with the patients. Here's a resident giving a talk on his laptop to the medical students. And so this has been a rich, sustaining relationship. Because of COVID, we've been using WhatsApp to communicate, consult, and talk with them there. So this is another way where we're reaching out globally. And then as I wrap up, with COVID hitting and with racism that became unearthed and in our face, our double pandemic, it really shifted our perspective, and it raised our voices on issues that have been existing over time, and gave us the strength and the courage to start to speak out and demand, like the Pitt medical students had their list of demands of the changes that were needed, that were necessary in order for it to be an environment that was helpful and supportive of them, the changes that needed to happen. And I'm so proud of them standing up and speaking out about the changes. And so this has really pushed us and forced us to really grapple with all of these issues. In dermatology, working with Camilla, a fourth-year medical student, we developed an action plan that was published that really gives folks the steps that we think are important to look at, both on the individual, the institution, and a societal view of racism in dermatology. And then lastly, what we're really trying to do through mentorship and through changes of how we evaluate applicants is to change our workforce, to really start young and start to talk about skin health, and to start to talk about the health professions when children are young, and seeing that this is a possibility for their career pathway, to change the lack of diversity in the specialty of dermatology, which the numbers are extremely low. And it's been historically sort of focused on these racially biased scoring, attainment, being voted into AOA. And we see those things being knocked down, which is great. And we're looking more holistically at applicants and their journey and what they've overcome and their care of patients, who's invested in our communities, what type of work are people involved in. And we're seeing a lot of changes there. One of the programs we're really excited, Cameron, a fourth-year medical student, has been working with Arsenal Middle School through the CHAMPS program And we're working with a group at Children's Hospital to deliver, information for students about what the skin is and how to take care of it. And I think it's important for the students to see a medical student delivering this talk and engaging with them and seeing them in her in their future. And so we're working very hard at all of these things and working on our culture in dermatology, and not isolating folks like I once was, and really engaging with them. And so we're making this shift, and this is where my vision is going. So we see skin health equity growing, MobileDerm growing, but I'd love to see it. My perspective is not just as individuals going out into the communities, but as an institution engaging with the communities. And there's a couple of things that I think that our institutions can really do to help make this happen. And that's health equity training, really sitting down and having training as to what health equity is and what it looks like. Looking at data, looking at our data of health in our communities, what's happening in our emergency rooms, in our clinics, who's no-shows, who's not being treated, who's being missed. And making these partnerships, these relationships, getting to know communities, understanding the community and how it functions, and making true friendships in these communities. Policies, looking at policies, using our vote and our voice in that healthcare arena. And again, there's the issue of power and agency that has to be addressed. And so my hope is that our healthcare complex, Pitt, the School of the Health Sciences, Pitt 1, UPMC, that we will start to shift our perspective and start looking outward and looking at our surrounding communities and support service learning and support community-based participatory research and advocacy and outreach and all of those to help ourselves do away with siloed programs, individual missions, these one-offs, and faculties who are struggling to make this happen and really supporting them and coming together in a unified way and a collective way to work with our powers and our communities and building power in our communities. So I'll close and go to a reflection again. And I think that we have to do this intentionally, maybe at the end of the week or end of a month, just assessing the situation ourselves and asking ourselves questions individually and of our institutions. What is our perspective? What is our level of community engagement? What is my role? And then looking at our institutions, what policies do we have? Who are the decision makers? I want to be in the room, like they say in Hamilton, where it's happening. Who is making the decisions as to what is important and what changes we're going to make? And what are we doing collectively to help build community health power? And so with that, I will close. I have so many people to thank for partnering with me, for supporting me. A huge thanks to the medical students who do a lot of this work, undergraduate students who have worked with me. I'm really thankful for their energy, their passion, and their vision of seeing the community. I'm thankful for so many people who have worked with me on the global and world level. So thankful for residents, colleagues supporting me, and I am thankful for my daughter and a Pitt student, Ms. Harper, for their art that represents our love and our commitment to skin health equity. Thank you.
I want to thank you so much, Dr. James, for this tremendous, thought-provoking call to action grand round. Excuse me. There are so many questions that I would love to ask and points to make, but I'm going to honor the time and go to the two questions that are in the Q&A at the moment, and also ask others to join us for the post grand rounds meet and greet so that other questions and other kudos can happen. So in the Q&A at the moment, we have from Dr. Amy Houtrow. First, thank you for sharing this important information about your story, and I would certainly echo that. So very important for all of us, including trainees, to understand the journey, the challenges, particularly in this month honoring women in medicine. The question is, I've started labeling some of the social determinants of health as political determinants of health. Can you talk about how the words we use address inequitable power dynamics?
Wow, that's a great question. And so I think that you're correct, and there are definitely political determinants of health, the governing issues, and that's kind of what in the skin, the health equity framework is that we have, politics, decision making, all of these different factors that are coming into play that govern health. And I think that's a really important approach that we have to have in this equity work, is looking at policies, rules that govern health. And so, yes, to your question and to your statement, is the language that we use and what we refer to, that there are lots of layers to equity and health, and there are politics, there is our society. Oftentimes those are overlapping themes. And so what we call them is really important to understand where it's coming from, yes, and how we are to address it. Is it our vote? It is who's governing, who's in control of these decision making. Those are definitely important factors when we are dealing with equity. I agree.
Thank you. And one last question. We are at the top of the hour. This is from Dr. Tanya Syed. First, she says, thank you, best grand rounds ever. I wish you could hear me clapping in person. And her question is, how do you fund the community and international work? Also, did you find challenges in our community with patients being able to fill prescriptions, which is something that we all, I think, find with dermatologic prescriptions? If so, how do you assist with this? And thanks again.
Yes, those are great questions. Funding is very important. I've been with the rural outreach. I was able to get a CTSI award to start off our program. We did the pinch program, and we proposed it, and they have been supporting us. So looking for grant funding, philanthropic funding is also important to ask for through the university. Our department, I'm very happy that our chair is supported, like supplies from our department that we are using. Our Derm Path services, they read our specimens free of charge. So we often have donations from the different departments. And the other question about community practices and medications, it's really amazing. And I've learned so much from community practices like Birmingham Clinic. They have social workers who are helping us. They have a team which is set up to help patients get the medications that they need. We had a patient who's had skin cancer, and we had to get them emergency insurance. And the team there was able to get them the insurance so that the patient could get their skin cancer taken care of. So the community practices that I am engaged with do a great job of looking for ways, patient assistant programs, and we're oftentimes very successful because their energy is towards really supporting and helping the patients get what they need. I find it's more supportive in those community practices often than the structure that we have at the healthcare complex.
Thank you once again very much, Dr. James. And we can continue this conversation if folks would like to click on the link for the meet and greet. And also a reminder, at 9:30, we will be rejoining our next workshop. Thank you again.